introduce you in that minute. Our next speaker is Michael Rudd. Not sure whether to call him professor or director of the, or ex-director or nothing.
No academic title.
Michael and I have known each other for many, many years, and he was the director of the burns unit at Royal Brisbane and Women's Hospital there for a number of years. Then he took on an out-of-town directorship, which was a bit tough. We won't mention any names, but he's got a few extra grey hairs as a consequence. And decision-making and clinical decision-making is one of his continuing enjoyments, shall I say. And he's also written a little bit about this in his research process as well. So, Michael, thank you for coming. Thank you for talking about timely access for surgery. And you're going to look a little bit more at the emergency and acute patient group for us today. Thank you.
Yeah, that's right, John. I have a very quiet voice, so can you guys hear me up the back? TK, yep, awesome. I'm a bit of a mumbler. Tell me to speak up. If you, so this is the thing. This is one of the things that this is one of those itches that I've been really wanting to scratch for a long time. I've been thinking about this for probably 2 decades, I reckon. For all the surgeons in the room, I'm sure you can relate to the, waiting to try and get your acute patient or your emergent patient onto an emergency board, but, being stuck in the line. That's not moving. When did it, Maybe I'll just use the button. There we go. All right. Okay, so I've got half an hour. I want to show you an example. This is sort of a little rabbit hole that I fell down a couple of years ago of the issue of access to the operating theatre. And then, because that's just one sort of small piece of the jigsaw puzzle, I'm going to spend half the time talking about that and then try and show you the whole puzzle. So the example comes from me being actually complaining about a patient that took 12 hours to transfer to Royal Brisbane Hospital. The spinal fracture patient developed some long tract signs on the general surgical ward in Caboolture, and by the time the patient got to Royal Brisbane, it was too late really to do anything that would have improved the patient's outcome. So I had a good old bitch to Jason Jenkins about this because he was the director of the surgical stream at the time. He said, I've got the job for you. I'm going to put you on a committee. In fact, I'm going to make you chair the committee to look into spinal fractures at Metro North. So from knowing nothing about spinal fractures, being a general surgeon who does burns, military surgery and trauma and acute surgery, I've had an education over the last couple of years. So we tried to reform the process of referral, and I soon discovered that there was some reform that needed in the service itself, because it's run by 2 separate specialties, neurosurgery and orthopaedic spine surgery, and communication could be better, cooperation could be better. And one of the things that came out of talking to the surgeons themselves was that it was almost like the reverse sort of Swiss cheese effect. So actually get a patient to theatre, you had to have the patient ready, you had to have the right surgeon, especially for the thoracolumbar, you know, complex spines. And then you actually had to find an operating theatre to do the patient in. And so access was obviously a problem. I did everything I could do without spending any money. And then we had a couple of business cases knocked back. And I thought, oh, bugger it. Obviously my arguments aren't good enough, so I'm going to have to go back and produce a stronger argument based on, you know, the data. So that was the beginning of the journey, and this is what happened, or more or less what I found. So 5 years worth of data for spinal fracture patients at Royal Brisbane. They have long lengths of stay, some mean length of stay of 12 days. And when you consider the average length of stay for an emergency patient, nationally is about 6 days. That's quite significant. When you look at the type of complications they get, well, and I don't know whether you guys can see this up the back, but we've got pressure areas, DVTs, pseudo obstructions, PEs, pneumonias, septicemia, neurosepsis from having, you know, catheters in for too long. So the pattern of injury, or at least the pattern of complications, very much looks like the kind of thing that you get from a patient who's been lying in bed for too long. And then when you look at what happens to the patients themselves, it's really not just the acute episode of care that tells the whole story, because 25% of the patients didn't go home. There were quite a few deaths amongst the patients who weren't operated on, and they were all, you know, generally old and frail. I haven't got that slide to show you, but when it came to looking at the length of stay for patients who actually got surgery, it was even longer. So median of 14 days, and then a mean average length of stay for patients who get surgery was 19 days. So, you know, really quite long. And just one of the things that I should have mentioned about the complications, so that's 500 complications in 1,400 patients. That's 1 in 3. So the average number of complications, or at least hospital-acquired complications, that you'd expect to see in a surgical cohort, and these are national figures, is 1 in 9. So it's a complication-rich cohort of patients as well. And then when you look at these patients, it's only a small proportion of patients that actually get operated on. It's about 1 in 10. But that 1 in 10, you know, the time that it takes to actually get them to the operating theatre, the mean time that it took was 77 hours, and the median time 42. So that's more than 3 days on average that it took to get these patients to theatre. And then when you looked at the patients that had their operations, it was an even higher proportion of patients that didn't go home. So when you're thinking about lengths of stay, acute length of stay, that obviously underestimates the burden that these patients you know, have on the healthcare system. So, and you can see patient selection was really good. There was only 3 out of 182 that died. And in terms of acuity, so this is injury severity scores. It's a complex, kind of strange categorical system that we use in trauma, from 1 to 75 or 3 to 75, that describes severity of injury. When you consider that something more than 12 is a major injury and probably involves more than one organ system, the majority of these patients were probably multi-trauma patients and had more than one organ system, and they were certainly, by definition, major cases. So once again, when I looked at complications in the patients that have been operated on, was the same kind of pattern of complications, except the incidence was higher. It was about 50%, so 86 complications in 182 patients. And once again, same kind of thing, aspiration pneumonia, pressure areas, pseudo-obstruction, PEs, aspiration pneumonia, and urosepsis. So just to summarise that part of the story, we've got admissions that are common. We've got long length of stay. We've got hospital-acquired complications that are, for a cohort compared to the average, very high. 25% of those patients weren't discharged and 4% of them died. And the ones that did get surgery, and when I ended up analysing the data, I added a couple of extra years in. I had 262 patients in the end who had longer admissions, higher rates of hospital-acquired complications, an even higher proportion that weren't discharged home, and the mean time to surgery from admission was 78 hours, and that's over 3 days before they got their surgery. So, I'm not going forward here. So, that was Peter McComb and Dennis Harvig that I talked to most about this issue, and I wanted to see whether there was some correlation between the patients that had complications and the time that it took to get to surgery. So the blue dotted cohort in the middle of the patients that actually didn't have complications, and the red dots are the complication events, because there are 142 events in 82 patients. And then the black dots on the far right are the patients who had complications. And you can see, and those mean and confidence intervals, they don't overlap. So there's a very significant differences amongst the 3 cohorts, or at least the 2 cohorts. And for a patient that went to the operating theatre and got a complication, the average time it took to get to the operating theatre was 100 hours. For a patient that didn't get a complication, their average time to get to the operating theatre was 50 hours. And then when I looked at length of stay, so blue on the right, blue on the left is the ones that didn't have complications, red is the group on the right that did. And this is something that, is a paradigm in surgery. You get a complication, you double or treble the length of stay. And it's just, wherever you look in the literature, this is basically what happens. You add a UTI to a patient's journey and they're in hospital for another 5 days. PE, they're probably in for another 2 weeks if they survive. So mean length of stay for patients who didn't have complications was 14 days and 30 if they did. I've got a bit of a geeky background. I've got 2 research degrees, and one of those degrees involved about 3.5 years of playing around with regression models. So I thought I'll develop a model and I'll look to see if I can work out whether these correlations between time to theatre and complications and length of stay, look to see whether they actually are independent predictors or not. So this is the model. It was a pretty simple one. So I used the variables that the patient came with that I could measure easily. So injury severity score, ASA, gender, age, numbers of fractures. I used time to the operating theatre. I didn't use the pre-hospital time. In fact, I ended up doing that, but I'm not going to show you that stuff. I looked at hospital-acquired complications, obviously, and then I measured 3 outcomes. I measured discharge disposition, length of stay, and complications. And the complications can be a cause of the other 2. Bear in mind, this isn't exactly a causal diagram, but just bear in mind that some of these things can cause, some of the variates in the boxes can actually cause or influence some of the other variates in the boxes. I mean, of course, it was all time dependent. So this is the univariate analysis that I did, and it was fun because I got to use almost every statistical test in the book, because if you look at the variates, some of them are continuous numeric, some of them are binary, some of them are categorical, some of them are ordinal. So I had a bit of fun doing that, but the point of this slide, and you don't have to interpret it all except to see all the red stuff. All the red stuff is significant. Okay, so there's a complex, I guess there are 2 things to say. First thing is I've hit gold because I found a lot of red stuff. The second thing to say is that clearly to try and work out whether I was going to, whether, you know, any of these correlating, these covariates or dependent variables and covariates, whether I was going to work out whether they really were independently predicting an outcome, I'd have to go and do some regression analysis. So this is the regression analysis that I did. I actually excluded all the patients that ended up being referred to PA because, you know, if your hypothesis is that you're lying around in bed before you get your surgery and then you can rehab, there's no point introducing the patients who lie in bed, get their surgery and then still lie in bed. I excluded those ones. So this is the logistic regression analysis that I did for complications. And as you can see, the only covariate that remained independent after you do the regression analysis was time to surgery, which is very significant. It's beautiful, in fact, and it's a really nice model too, when you look at the ROC curve. When you look at length of stay, once again, complications are important. Time to surgery looks like it's important, but it's a kind of an oxymoron. If you add, for every, those numbers say that if you add a day pre-op, you add a day post-op. So, that just tells me that my model isn't a stupid one. And then when you look at patients discharged home or not, you can see that probably the most important factor that affects whether they're discharged home or not is age, injury and comorbidity. And I think that's quite telling, considering we've been talking about frailty and we've been talking about models of care that involve geriatrics. So I was really interested to see that as well. And it's always important when you're doing work like this, so you develop a model, but it's really important to go back and look at the raw data and see whether your model reflects the raw data. And in this case, the odds ratio for developing a complication was 1.2. So that means that every time you add a day to the patient's pre-op journey, you increase the risk by 1.2. And that's the raw data over there. And this is the odds ratio, the cumulative odds ratio, which is sort of like squaring it each time you add another day. So by 144 hours, you should be somewhere here. And before 24 hours, you should be somewhere down there, 1.2. So the model actually makes sense. And just in conclusion to this, how am I going for time? How many? I've got 5 more minutes, so I've got, okay. To prevent complications, reduce length of stay and discharging our patients home, you know, how do we actually improve that? Well, obviously we need to reduce the time to the operating theatre. We're going to reduce length of stay. The only thing that we can do is reduce complications by reducing the time to the operating theatre. And then in terms of patients being discharged home, really the only thing that we can do, because age is the important factor here, is center a model of care on a kind of a multidisciplinary rehab model. Now, I'm going to have to run through this quickly because I'll probably spend a little bit too much time. So this is the context to this. This is national data. We have the predominant surgery that we do is elective surgery. So, and most of our elective surgery is done in private hospitals. Emergency surgery, most of it's done in public hospitals, but it only forms about 1/3 of the surgery that we do. But when you look at my hospital, Royal Brisbane Hospital, and that's the one on the right there, and this is Health Roundtable data, you can see that that's about right. In fact, it's a bit more elective surgery at Royal Brisbane. But the length of stay for elective patients is only 1.38 days. The length of stay for emergency patients is 6 days. And so when you look at the burden of care in terms of bed days, elective surgery turns out to be 35,000 bed days. Emergency surgery is 48,000. So it's sort of inverse. Bed days and patients. And then this graph down here is just the patient days before they got surgery for acute patients, for acute emergency patients. And you can see, and these are just patients that have had one operation. It's not the burns, it's not the other patients that require several operations. The number of bed days, number of pre-op bed days was 11,295. That's the equivalent of a whole ward, a 30-bed ward for a year. So certainly room for us to improve. Emergency surgery has been reformed in 3 states. So we have categorisation systems in 3 states, Queensland, New South Wales and Victoria. This is just stuff that I could find. So if the West Australians had a categorical triage system, they're keeping it under wraps. And you can see that there's some minor differences, but they're basically, you know, 1 to 5 or 1 to 6 different categories. This is reporting of elective versus emergency surgery at Royal Brisbane Hospital. You can only actually see the emergency surgery at the bottom. But the point I wanted to make from this diagram is that it's extremely predictable, you know, at a hospital level. It doesn't go up and down from month to month. It's very predictable. We should be able to manage it because it is predictable. And then the breaches. So we've got a categorical system, 1 to 5, that tells us about by which we triage our emergency patients to get to the operating theatre. And this is new data. This hasn't been produced for a long time and it's not widely published, but at Royal Brisbane we run at about 20% breaches for emergency surgery. So 1 in 5 patients doesn't get their operation within time. For elective surgery, long waits, breaches, which is reported and which has pressure, both political and public pressure to sort of achieve very low rates of breach. At Royal Brisbane and across the nation, it's much, much lower. 0.9% is the standard that we aim for in Queensland. So I think reporting has a lot to do with the rate of breaches that we see. And this is just me trying to find reporting at national, state and local levels. And it's easy to find it in elective surgery. I can't find it, except the stuff that we have at Royal Brisbane at either a national, state or a local level. So I'm going to run out of time, but I just wanted to make the point that in emergency surgery, we've been talking about the golden hour for a long time. And, the only criticism of the golden hour is that for some cohorts of patients, it's really the golden 10 minutes. And for other patients, it might be the golden 2 hours for extradurals, for instance. And if you extrapolate that concept to acute surgery, then, there are a whole lot of different hours or fractions of hours or multiples of hours. And when you look at the literature, I've got the number of studies down on the right-hand side, and I've got the time that they've sort of come up with on the left-hand side. And you can see that there are a whole lot of different times that have been accepted. The pink cohorts, like open fractures, necrotizing soft tissue injuries, hip fractures, extradurals, closed femoral fractures, cholecystitis and appendicitis. So they've done meta-analyses, and there have been recommendations made by international sort of consensus groups. So it's not like it's just one or two, piddly little papers. And then, if I were to, and then there are another 16 studies where they looked at process for emergency surgery and acute surgery. If you remember that sort of simple model that I came up with for my regression analysis, this is more like the accumulation of the accepted wisdom in the literature as to what your model should look like. If you're going to get 100% predictive value as opposed to sort of 75% predictive value, you'd include rehab for a start. You'd have your pre-hospital times. You'd have all of the patient variables which are important, including frailty. I think I might have missed obesity. Physical resources, the hospital type, bed access to diagnostics, surgery, therapeutic access, and then governance over the top of that, human resource variables, seniority, triage, diagnosis, technical superiority, and then surgical culture and leadership. And then these are all the outcomes that we could measure. And then when you think you've got it all worked out, you have an act of nature like COVID come along, which will blow the whole thing out of the water. So just in summary, for emergency surgery, 40% of the patients, 60% of the beds, very high incidence of breaches and no public scrutiny and reporting. And there's mounting evidence that in some cohorts, there's a causal relationship between time to surgery and outcome. I probably should leave it there, shouldn't I? Thank you.
Thanks, Michael. Any comments? If you're going tomorrow, there's a very sound reinforcement in one of the speakers tomorrow afternoon on that very subject. Chris Allen.
Chris Allen, General Surgeon at the Mark. Michael, so I was keen to see your take then on your recommendation for the golden 24 hours or 48 hours of time to surgery from someone, obviously from your study there, of someone with a spinal fracture.
It's about 48 hours. I think that 48 hours is a safe time to get a spinal fracture to surgery, but for all of these different cohorts, there are going to be different times. It's quite, I think it would be wrong to think that we can just open up a few more theatres and we'll get best bang for our buck. I think we've got to be more sophisticated. We've got to look at the data. We've got to look at the cohorts that are going to benefit most from having better access to the operating theatre rather than just think if we throw resource at it, we'll fix the problem. And then the converse is that if you look at the data from my hospital anyway, 15% of the utilisation in elective surgery is actually small emergency cases that they put on the end of their lists to achieve that 80%. So I'm not at all advocating that we should sort of quarantine elective surgery from emergency surgery. What I do think is that the key is analysing the data in a sophisticated way so that we can come up with sophisticated solutions.
The solution that will come from that, though, will be something like the 4-hour rule or the 2-week rule for referral of soft tissue masses, which is something I saw in the UK. But I can just see that that's going to come. You know, this is very powerful, compelling data that you're presenting here, Michael, and it will, you know, I would have thought it will be forced upon us from.
Are you concerned about that, Chris?
Oh no, I'm not concerned at all. I'm not concerned. I think, well, it should. You know, we should be doing something about this. We should be reacting to this, and because if we don't, you know, some bureaucrat will get a hold of this, and we will just be then compelled.
TK? Oh, sorry. I agree with you, Chris. I think we need to be the masters of our own destiny. We should come up with the solutions. Martin? Oh, TK?
Martin Woolschläger, working with Michael now, with Michael Rudd. I've known this data a bit beforehand, and now I completely agree with Chris. It's very powerful. We just have to be careful it's not getting out of hand, because it can turn the back on us, obviously. But yes, in a lot of hospitals, the administrators looking for reasons, and also then for numbers, and ultimately then high up for targets. But as we already started in this group and a bit beyond, to really have a thorough discussion about emergency surgery where we want to put targets, because I'm not a fan of targets. It's just more on us and NEXEC, but I think it's still one way to go. It's not the ultimate way, I think, but it's one way to go. But we need to steer it, and we need to lead it. Otherwise, it can get out of hands. And I also agree with you, Michael. Just to put more emergency theatres on, it's not a solution. We need to be clever about it, but very powerful. Thank you.
Peter Shell, BBC. There is a caveat. John sent me an audit meeting, audit of a death earlier this year. No names, no pack drill. Emergency paraparesis from, as it was, malignancy. Operation needs to be done, decompress the spinal cord, certainly. Everything went, you know, there. And I looked at it all and said, well, you know, the outcome was very likely that this patient would pass away, because they were, you know, had a list of miles long of comorbidities. But then, just at the end of it, said, well, the operation started at midnight and the table fell over.
Yeah.
So things can go wrong.
I agree. I agree. I'm just thinking about Chris and Martin's comments. I think if you look at elective surgery, we have 3 categories. It is reported now, and though I think that categorisation system has been set up, you know, based on the concept of having fair access for elective surgery. In terms of evidence-based research into, you know, elective surgery, and, you know, whether a month or 3 months or a year make a difference to a particular type of you know, problem, I could fit the evidence into a matchbox, because there is none. So that's a system that's just been set up by going, we'll do this. What I'm suggesting we do is we actually look at the evidence and develop a sophisticated system that works better than the one that we have at the moment, based on the data.
Yeah, thank you for that. I think that's a terrific talk. I've been saying for ages that because of the targets that have been determined, we focus on elective surgery. But we need to look after our sickest patients first. And I think emergency surgery gets an add-on, and we are doing cases, you know, at midnight. I'm not afraid of the data, because I think that's the only way that will convince people like Nick Steele to then, you know, throw some money at it. Do you think with your data, with some crafts, like if you started with whatever, even orthopedics or neuro who have high emergencies, like orthopedics normally operate at about a 53 to 54% emergency rate, could you come up with a
Absolutely.
equation?
Absolutely.
It's not just about emergency theatres, but you could look at, okay, if you have 10 orthopods and you're 53% emergency, these are your number of cases, you need this many elective theatres, this many, you know, theatres for orthopaedic emergencies and that. Over the years, we have tried things, you know, do the NOF first case, you know, in the morning, all of this sort of thing. But we're still talking about the same things that we talked about 20 years ago.
Yeah.
So we need the maths and we need the data to
Yeah,
convince
we
it to
do.
change.
The other thing I'd say about these two cohorts of patients is that, you know, I've been a director of you do get a lot of complaints from patients on elective waiting lists who are waiting for their operations, who are well enough to complain. Okay, acute and emergency surgery patients lying in hospital, stoned because they're on an opiate infusion. You go along to see them and you say, well, I don't know when you're going to get your surgery. You know, we've got an emergency board running, but, you know, if somebody comes in who's worse than you, we're going to do them first. I've been working for 20, probably 30 years, if you count my training as well. I've never had someone complain. They're too vulnerable and they're too sick to complain. And you know, really, we haven't been good enough advocates for this, for reforming this in this area.
Thank you, Michael. We've talked about this before, and it's something I'm very passionate about. These are the most vulnerable cohort of patients, and they just don't get any visibility. I mean, my theatre complex at Logan, 50% of my work is emergency, and they're just pariahs who get in the way of me being able to do elective cases. They're just a burden, and they shouldn't be that way. These are the most, and the other thing is too, I get held as an acute surgeon. My outcomes get held to account the same as the elective surgeon. So my outcomes, without all the love at the front end, I still get, you know, a death is a death, and a urinary tract infection's a urinary tract infection. You still get marked on the same, but you don't get anything at the front end of things. So I think, I'm not sure what self-respecting health service chief executive is going to sign up to any sort of targets, because they're not really meetable. I know from the Logan point of view, unless we get extra facilities, we're not going to be able to meet any sort of target. So I suspect it's going to have to come down from someone in the government to say, if you want an agreement with us, you're going to have to sign up to some sort of target. But I agree we have to be the ones who are driving it, so that it can be, you know, patient-centred and actually what's actually right, not just a 4-hour rule that's like, well, so I choose 4 hours or something like that.
And I'm not a, you know, I don't want to make, I think that this is a public resource, and that, you know, that we should have 80% theatre utilisation for our elective and our emergency surgery patients. You know, I'm an advocate for that as well. But I'm worried that if we choose the wrong solution for emergency surgery, we won't achieve those efficiencies as well. So we've got to be really, really careful about how we do this. I'm just demonstrating a problem. I can't tell you that I've got all the solutions for it. But I do think that we've got an inequitable system at the moment.
Brian McGowan, Brisbane. Thanks, Michael. Again, it's a really good example of pulling some data out of the system and showing what the implications are. And you already touched on that comment you made about the evidence around the elective surgery categorisation, sort of, as you say, fits in a matchbox and with room to spare probably. There's very little, if any, categorisation around. It's purely a political activity target or activity prediction, and it's astrology. what
couldn't
you've got
disagree with you.
in your presentation is actual hard data. That's not astrology. But the conversation is likely to be, yes, we need to fix things for our emergency patients. Possibly the price will be you're going to have to give up something in your elective thing. The pie is only so big. Everyone accepts we can't just keep pouring more and more into the health service, but it's a question of priorities, and I think we have to guide the prioritisation of care for the emergency patients, and we'll all probably have to say, well, we probably have to do fewer umbilical hernias or fewer widgets or whatever it is, and that should be a clinical decision as well, that we help make it easier for the politicians to get the balance right. And the only way to make emergency surgery happen is it has to become a KPI, just like the elective surgery is a KPI, to get the attention plus testicles or ovaries of the executive.
Yeah, I agree.
I mean, I think emergency surgery is what drives most health workers. You know, we want to get sick people well,
yeah,
and that's what politicians have depended upon. That, you know, they put pressure on the basis that they assume the fact that emergencies are going to get the priority. So where I'm coming from in Cairns, there is only one emergency department in the whole area, and that happens to be Cairns Hospital, and there is no private emergency at all, or virtually nil, and it's 50%, and this year it's 53% emergency surgery. So we are cancelling elective surgery all the time to do the emergencies every day, and also elective surgery is cancelled because there are no beds, for the very reason that you say that the emergency people take up more beds. But from the administrator's point of view, all they see is that we've cancelled elective surgery and that we're not meeting our elective surgery targets. And that is what happens when you have no KPI for emergency surgery.
I agree completely. I think there's this perception that, you know, with NEAT and NES, that, you know, it's really, really important to get your patients out of the ED department because it's really, really important. And it's really, really important to operate on elective patients because it's fair, and that's a political statement. And I think there's this ignorance or assumption that once a patient gets out of the ED department into a bed, that it's like it's some kind of magical place where nothing goes wrong. And we all know that the last place in the world I would want to be is in a hospital bed waiting for something to happen, because only bad shit happens.
I think we'll have one more question.
Thank you. Sanjeev here. Just, I think it's not about KPIs. I think what we need, because as Michael was saying, you put another KPI into the Cs, they won't want it. What it needs to be driven as is a quality or safety indicator, where it's prems and proms, and, you know, when there's delay in surgery, there's complications. We need to drive that. As part of our chair sitting here as surgical advisory, and there's a few members through the SEC, we are looking at how to bring a recognition of emergency surgery as an important part of our workload, so that it's recognized and not put in the back burner somewhere. It is very, very important that we do that, because I think you can see that if we get our, in particular in Metro South, for example, which is my patch, if we get our emergency surgery workload through, we can do more elective cases. It's a no-brainer exercise, but we're not moving forward. We don't have the courage to move that forward. In fact, what should happen is the clinicians need to gather up, like the orthopedic group in Queensland, and it has given them significant power, authority to say, this is what we want to do. And all the surgical specialties need to power up like that and have a chair and have a voice through Rob, who's our chair at the moment. If we can get that going, we need to take control of this situation rather than being told what to do. And one of the things I told Matt as head of Metro South Surgery one day when he rang up to say, I've got 50 odd patients on that, well, cancel your damn elective surgery, because that'll then put a bee in the bonnet of the other guy. So it's one of the ways we can take control of the situation. That's the only way you get it, some sort of acknowledgement. But emergency surgery is vital. We need to do them first, as PK said. They're the sickest people.
I'm sorry I took so much time.
Thank you, Michael, very much.